Hello, and welcome to a Facebook Live broadcast with MedStar Georgetown University Hospital. My name is Karen Zingle, and I'm joined today by orthopedic surgeon, Dr. Brent Weasel, who is our Chief of Shoulder and Elbow Surgery at MedStar Georgetown, physical therapist, Dr. Fareed Boulalam, and their patient, Elizabeth Harrington. At MedStar Georgetown, part of MedStar Orthopedic Institute, we offer the most advanced care and treatment for rotator cuff, shoulder replacements, and other painful shoulder conditions. We offer a variety of cutting-edge procedures that benefit you with more precise surgery, faster recovery times, better pain management, and better results. So if you'd like to learn more about the conditions that cause shoulder pain and the diagnosis and treatments for it, then stick around, share this broadcast with your friends, and please ask your questions for our panel in the comments below. Dr. Weasel, Dr. Boulalam, and Elizabeth, welcome. Thank you for joining us. We really appreciate you taking the time out of your day to talk with us.
Thanks for having us.
Thank you.
My pleasure.
Before we begin our discussion, Dr. Weasel, let's start with you. Will you tell our viewers a little bit about yourself and your expertise as an orthopedic surgeon?
Sure. Thanks, Karen. My name is Brent Weasel. I'm an orthopedic surgeon here at MedStar Georgetown. My specialty is shoulder and elbow surgery. So about 90 to 95% of my practice is dedicated to treating shoulder conditions. Been here for about 13 years. I see patients here at Georgetown as well as in our office in Chevy Chase at 5454 Wisconsin Avenue, and then out in McLean as well. My interest in shoulder and elbow surgery actually came from a personal experience. I was training for the 1996 Olympics in whitewater kayaking, dislocated my shoulder, had to have 2 surgeries on it. We weren't quite as good at doing those as we are now, so I was not able to go back to compete in the Olympics. Was able to go back to kayaking, but not to Olympic level. So ended up going on to medical school up in Philadelphia at the University of Pennsylvania, and then I've been back here in Washington since 2008, and love taking care of shoulders.
Great, thank you very much. And Fareed, why don't you also tell the viewers about yourself and your expertise in treating shoulder patients?
Yes, thank you, Karen. My name is Fareed Boulalam. I'm a doctor of physical therapy, as well as a certified strength and conditioning specialist and a credentialed clinical instructor. I went to physical therapy school at the University of Maryland, Baltimore, and I treat a variety of orthopedic conditions, as well as patient populations with a specific interest, obviously, in shoulder, which is why I'm here, and excellent outcomes in the shoulder. I don't have a personal experience like Dr. Weasel. However, I am extremely interested in the shoulder. It's extremely fascinating. And yeah, I love treating shoulder and the patients that come and see me. My caseload currently consists of 50 to 60% shoulder cases. And currently I am a float physical therapist floating between Chevy Chase and Wheaton in the next coming weeks.
Great, thank you both very much. And we'll hear from your patient, Elizabeth, in just a moment. But let's start off with some questions. First, I want to talk about just anatomy and conditions of the shoulder. So these questions are for you, Dr. Weasel. Can you talk about what makes up the shoulder joint?
Sure. So when we talk about the shoulder, it's actually not just one joint. It's a combination of 3 joints and really made up of 3 bones and then the muscles and tendons that surround them. So we've got a shoulder model here. When we talk about 3 bones, we're talking about the clavicle, which you may know as the collarbone. And then you've got the shoulder blade itself, which comes up and forms this little process on the end called the acromion. And then you've got the humerus, which makes up the ball of the shoulder joint, and then this goes on down to the arm bone. So when you talk about the shoulder joint, we've got the ball and socket joint, which is hidden here underneath our rotator cuff tendons. We've also got the joint where the collarbone meets the top of the shoulder blade. It's called the acromioclavicular joint. And then we have the joint where this whole thing, as you don't think about much, but it's called the scapulothoracic joint, where this whole shoulder blade sits on the back of your chest. In addition to that, then we've got the muscles and tendons around it that surround it. The one you hear about the most is the rotator cuff. And that's a series of 4 muscles that starts here on the shoulder blade, and they insert here on the ball. And the purpose of them is to keep the ball centered on the socket so that then your big muscles are able to move the arm around essentially where you want it in space to put the hand where you need it. And so those 4 rotator cuff muscles, you've got something in the front here called the subscapularis, and you've got one up here at the top called the supraspinatus, and 2 in the back, the infraspinatus and the teres minor. And everybody always wants to know, which rotator cuff muscle are you talking about? It's a little bit of a misnomer because while they start in different places, what you can see a little bit on this model is they insert here as one sheet of tissue. So they really all come together in one spot that extends here from the front all the way around the top to the back. And so even up here in the front, there's some contribution from this muscle in the back and vice versa. So it's when you talk about a rotator cuff muscle, for example, being torn, you're talking about the tendon, and it's really a portion of all 4 of them that'll be torn. It's just a question of how big the tear is.
Thank you very much. That was really helpful. It's a very complex area of your body. You didn't even realize how everything all works together. So thank you for showing us that demonstration. That was really helpful. So let's talk about shoulder pain. What are the common causes of shoulder pain?
So when you start talking about shoulder pain, the causes sort of relate in a lot of ways to age. And so in young folks, the most common thing we see, and by young, I mean sort of anybody under the age of 30 or 35, is a dislocation of the shoulder joint. And what that means is the ball and socket joint here, the ball will actually come out of the socket. As we start to get older than that, so 30s and beyond, we start to see a lot of problems. And the most common thing we'll see is problems with the rotator cuff. And those are either degeneration or inflammation of the rotator cuff, or actually tearing of the rotator cuff. And then in patients sort of from the mid 50s to 60s and beyond, we'll start to see a lot of arthritis, which is wearing out of the joint where the actual cartilage surface of itself that used to be 1,000 times smoother than ice starts to look like a gravel road. And that's similar to the arthritis that we see in the knee and the hip. We'll also sort of in all age groups, but especially in more older patients, we do see fractures of the bones as well with proximal femurs.
Thank you. So you mentioned rotator cuff a couple times. Can we talk a little bit more about that in particular? And what are the causes of rotator cuff problems and why are they so common?
So, yeah, I mean, when you talk about shoulder, everybody thinks they have a rotator cuff problem because it's the most common thing we see, and the vast majority of the time it is. And the reason for that, why rotator cuff problems are so common, we're not entirely sure, but if we go back to the model here and look, you can see that the rotator cuff passes underneath, I sort of mentioned this top of the shoulder blade here. It passes underneath this arch made by the top of the shoulder blade and the ligaments connecting the shoulder in the front. And so as you raise the arm and move it, it's very easy for that cuff to rub either on that bone there or on the ligament over top of it. We used to think that all rotator cuff tears were actually caused by this bone up here sticking down and digging into the rotator cuff. We now know that's not entirely true. And actually, in addition to that kind of mechanical effect, this area up here at the top of the rotator cuff has a tendency to degenerate as we get old. It's sort of like the gray hair of the shoulder. And so we know if we look at people in their 80s, about 80 or 90% of them will actually have tears of their rotator cuff. And that starts as early as the 40s. And so that is by far the most common cause of problems in the shoulder. A vast majority of what I take care of.
Thank you. When do rotator cuffs problems typically present themselves and how?
So, they tend to start sort of in the late 30s and beyond and become more prevalent as folks get older. And the most common presentation is pain, and it's not actually pain right here at the top of the shoulder. It tends to be pain kind of over the anterior lateral arm. And the reason for that is the structure we're talking about is about 3 layers deep. And so the pain is referred kind of down into this area. It often will bother people with overhead activity. And then also, again, interestingly, and kind of very stereotypically at night. So it tends to be a pain. A lot of times it will wake people up from sleep. And then if there's actually a tear of the rotator cuff, they may in addition notice some weakness. So I think now might be a good time to have Elizabeth sort of step in here and tell us a little bit about how her rotator cuff issues presented.
Yes, thank you, Elizabeth. Go ahead.
So interestingly enough, it was through activities. I'm a fairly active person, and maybe about 10 years ago, I was playing tennis on a team, and serving that continual motion was really painful, and I actually had to stop. This time around, I was experiencing a lot of pain because, like Dr. Weasel, I am a whitewater kayaker. And so when you get older, you hopefully get wiser. And I decided that I wasn't going to let my body stop me from doing what I wanted to do when I knew that I could have a surgical intervention that would get me back to my goals. So it was very painful, and I had some weakness, and I did go the route of physical therapy. I had cortisone shots, way too many to really share. And then through word of mouth, through my kayaking friends, found out about Dr. Weasel, and just based on his experiences and having been, having trained for the Olympics, I decided he was the person that I wanted. And I am back to kayaking, and my surgery was in October.
Wonderful. Thank you, Elizabeth. Thank you for your time today as well. Dr. Weasel, do all patients with rotator cuff problems need surgery?
So no, so the vast majority of patients with rotator cuff problems, we can actually make better without surgery, either with a combination of, either primarily with physical therapy, sometimes with a combination of a cortisone injection as well.
Thank you. And Elizabeth, I understand there was some physical therapy that you also have been doing since your surgery. Can you tell us a little bit about that?
Yes. So I've been working with Fareed, and I have to say that it is a long process. For the first month after surgery, you're in a sling, and I too decided to bring my prop because this becomes your best friend for about a month. But after that time, when you start that physical therapy process, it was about 2 times a week, and then down to 1 time a week, and now every other week. And I'm actually, this week is my last appointment. And I'm really grateful for the work that Fareed has done with me. He's really worked on not only the strengthening, but also my range of motion. And the one piece that everybody told me, the advice that everyone gave me, is make sure you do your physical therapy religiously. And that's what you have to do. It's a committed process. And by going to the appointments and by working with Fareed and increasing the strengthening exercises and the different types of exercises was really helpful. I don't think I ever would have done push-ups where I'm not on my knees on my own. And Fareed is really good at motivating folks because he gets right down on the floor and does them with you. So anyway, it's been a pleasure.
Thank you, Elizabeth. Fareed, can we talk a little bit about the physical therapy, especially, let's talk about, I want to hear a little bit about before and after. So maybe we start with before surgery. So if a patient does in fact need surgery, based off of what Dr. Weasel had mentioned, what is the experience that what does it look like to do physical therapy before surgery for a rotator cuff problem?
So before surgery for a rotator cuff, and this is the way I treat with everyone. As you can see, Elizabeth and I have created that therapeutic alliance. So I think that's extremely important in creating with your patients as a physical therapist. We know that the higher the therapeutic alliance, the better the outcome. And that is exactly why I don't mind working out with the patient, because it just shows the patient that, yeah, their physical therapist can do this as well, and they're showing support. And sometimes the patient does better than the physical therapist. So it just shows that therapeutic alliance and that it's a team effort. It's not just me, it's not just them, it's a team effort to not only attain their goals, but their future goals as well. So that's just the gist of physical therapy in general. And then for rotator cuff problems specifically, a lot of it is really figuring out what are they doing outside of PT, right? A lot of patients come in with shoulder pain, persisting or not, and just figuring out what did they do. Are they doing too little for too long? Are they doing too much too quickly to perhaps flare them up? Dr. Weasel did talk about the rotator cuff tears and, the decreased space within the shoulder capsule, which again is part of the patient's story. So they may have rotator cuff tears, which can be priming their nervous system to have sensitivities. And, we'll talk about this a little bit more, but yeah, after PT, not all patients do get better, and they are warranted for surgery because of unknown reasons. There are a lot of people that have rotator cuff tears and have no symptoms, but there are some that just have persisting pain and dysfunction, and that's when Dr. Weasel steps in and does, his magic. So a lot of it's identifying that. So finding the right balance in their activity level. And that's what I'm there for. I'm there to educate them on what they're coming in with, guide them through what they're doing on their own, and then fine tuning what they need to be doing. And that's not only through exercises that I give them, but also activity modifications. Maybe they need to back off and let things calm down and get them back to doing what they were doing with my guidance, of course. Giving them exercises to desensitize the shoulder, allowing for decreased symptomatologies, increased range of motion, strength, capacity, and tolerance for the things that they need to do. The exercises can range from pulley exercises, TheraBand exercises, weighted exercises, dumbbells, kettlebells, sometimes getting on the floor, depending on the patient, of course, and wall exercises, and essentially doing them on their own. I see patients 1 to 2 times a week, because at the end of the day, they can come in and see me every day, but if they're not doing the things that we've discussed, as well as their exercises on their own, they're not going to get what they need to be getting out of PT. So it's trial and error. Everyone's a little different. So just working together to try to find what's best for each patient individually.
Thank you. And Elizabeth, sorry, did you have something to add?
Yeah, I was just going to share, when you asked if every patient needs a surgical intervention, I know, again, I had gone through 3 years of physical therapy and I think 5 cortisone injections. I think it also depends on the activity. So, when I mentioned tennis, that's one in which that range of motion is really involves the shoulder. The other one that I do, kayaking, also involves that shoulder a lot. And so for some, it might be between my tennis and my kayaking, I was doing okay. And so it wasn't until I began certain activities that I love that, again, use that shoulder that required additional interventions for me. And I go back to what Fareed said, that doing the physical therapy, not just in your office, but at home, is paramount to, rediscovering that range of motion and the strength to do the things that you love.
Thank you, Elizabeth. Can you tell us a little bit about your experience with the surgery itself?
So it's It's in and out. I mean, you know, obviously speaking to Dr. Weasel ahead of time, knowing what to expect, and he's very good at his craft. So it doesn't take a long time for the actual surgery itself. He's also very clear in terms of the time it will take to heal. So when I showed that prop, I mean, I did it kind of in jest, but it really does become your best friend for a month, because I have long hair. And for the first, I can't even remember how long, I couldn't tie my own hair up. And so you're limited in your physical abilities, and you really, you need assistance. After a set amount of time, I remember actually the first time I was able to tie my own hair up, and I saw Dr. Weasel that day, and I said, I was able to tie my hair up. And he said, wait, you're not supposed to be doing that. And I said, oops. So it's sometimes—
You were excited.
I was very excited. So, but sometimes it's a matter of slowing down in order to go fast. So you have to be patient with yourself, and you have to give yourself grace, and you have to be okay with relying on others. So it was painful before, and sometimes there are little bits of pain, but it's a long recovery. Dr. Weasel shared with me that full recovery really is between 16 and 18 months. Now, that doesn't mean that you can't fully do some of the things that you want to do before then. It just means that you, again, have to give yourself grace and be patient.
Thank you. The prop that you brought, is that a shoulder sling? Can you tell us a little bit more about that? I'm very interested in it. I'm sure
yes.
you're interested in it. Is
So
it a little bag?
Yeah, so this was given to me after surgery, and you sleep with it on. The only thing that you don't do with this on is bathe. I mean, I had it on constantly, and it protects you from moving in ways that you really don't want to move your shoulder, because otherwise you have that breath. It's like being kicked in the gut. So, but like all things, there's light at the end of the tunnel, and so yes, that sling was definitely a godsend.
Great, thank you. We have lots of questions from our viewers, so thank you all for submitting your questions. I have some more questions for you as well, so we'll get to those. If you're just joining us, thank you for joining us today. We are discussing shoulder pain and treatments with orthopedic surgeon Dr. Brent Weasel, physical therapist Dr. Fareed Boulalam, and our patient Elizabeth, who has been sharing her story on her rotator cuff surgery and her journey. And she's been sharing her experience. So let's get into a couple of the questions that we've received so far. Again, we have lots of them. So let's start with this is actually a comment that I'll share with Dr. Weasel, I think echoing what Elizabeth had said in her praise for Dr. Weasel. This one's from Nancy. She says that you had operated on her shoulder 2 years ago, and it was the best thing I ever did. Have a new shoulder and can use it with no pain. So God bless Dr. Weasel. So that was from Nancy. So not exactly a question, but a good comment.
Very nice.
Mandy has a question. She has been having problems taking her arm above 45 degrees without turning out her arm into an external rotation. There's no specific pain, but why is that? Is there something to do with your shoulder and how much movement you have? And would there be some type of reason for you to get checked out, even if there isn't any pain? Dr. Weasel?
You know, certainly if you compare it to the others, some people, you know, if it's the same on both sides, that may be the way you've always been. But if it's something you've noticed it's changed, or it's different from the other side, that's certainly something I would have looked at. It could be an issue of, as you start to bring it up, you are getting some pain from that rotator cuff, and so your body's smart, and so your body's making you start to avoid that position. It also, you know, there's an entity called frozen shoulder, where the shoulder joint itself gets very stiff, unrelated to the rotator cuff. And that could also be what's going on. But either one of those, once you kind of have the diagnosis, most of the time you're going to end up working with Fareed or one of his associates, and you can make that better.
Thank you very much. And thank you, Mandy, for that question. There's a question from Warren. Is torn muscles the same as rotator? Is a torn muscle the same as a rotator cuff? I'm not, maybe can you tear a muscle in your rotator cuff, or is there some type of, can you talk about torn muscles in your shoulder? That might help Warren a little bit.
Yeah, so I mean, when you talk about tearing something in the shoulder, we're almost always talking about the rotator cuff tendon, not the muscle. Very rarely you can tear, the tendon. So when we talk about tears, it's typically coming right off the bone here. It is possible to tear, I'll show you in the back, although this normally happens up in the top, but it is possible to tear the tendon off of the muscle. That's something that actually most of the time will fill in and heal with scar tissue, kind of basically on its own. But almost always when you talk about a rotator cuff tear, you're talking about tearing the tendon off the bone. And it's a little confusing because there it is, when we talk about the rotator cuff muscles, we're talking about both a muscle and then the tendon where they insert into the bone. So the nomenclature gets mixed up a little bit.
Thank you. You mentioned frozen shoulder earlier in a previous question. Myra asks, can you talk a little bit more about frozen shoulder? Describe it for us again. Her husband had frozen shoulder based on an X-ray only, and his physical therapist. So she wanted to learn some more about frozen shoulder and what can be done there.
Sure. Why don't I talk a little bit about it, and then I'm going to kick it over to Fareed, and he can kind of talk about what to do about it. So frozen shoulder is an entity where the lining of the shoulder joint itself gets inflamed, and then you get progressive decreased range of motion in the joint. And, her experience with her husband's correct in the sense that you do need an X-ray in order to diagnose it. Not that the X-ray shows you that there's frozen shoulder going on, but the X-ray shows you that there's no other reason for the shoulder to be stiff. That primary reason is often, or the other thing that primarily causes stiffness is arthritis. So you need the X-ray really to make sure that you don't have arthritis. But assuming that you don't, and you do have frozen shoulder, it's an entity that's more common in women than men, typically between the ages of 40 and 70, although it does happen in men as well. And then also in people with diabetes or problems with their thyroid, either hyper or hypothyroid. And the good news with it is it almost never needs surgery. So the vast majority of people will get better without surgery. The bad news with it is it takes a really long time to get better. The average duration of symptoms is about 12 to 18 months. And so it really is it's a long process, and the patients with it get to know their therapist very, very well. So let me let Fareed talk a little bit about what he does in terms of therapy for that.
Yeah, thank you, Dr. Weasel. Yeah, so like Dr. Weasel said, it takes a very long time. But with that being said, I am essentially there to educate patients on frozen shoulder. It is something that luckily is self-limiting, so it will get better with time. So a lot of it's just educating the patient on, well, first and foremost, it's okay to start moving the shoulder. A lot of patients don't want to move it for fear of damaging something or regressing something. So a lot of it's just educating them and just telling them, hey, it's okay to move a little bit. Obviously I tell patients, look, it's okay to poke into symptoms, not necessarily push through them, because a lot of times when you push through pain, you're pushing through high levels of pain, and sometimes that can flare patients up even more so. So moving within the constraints of what patients come in with in regards to symptomatologies. So that in and of itself helps patients desensitize the shoulder, helping them feel better. I educate them on modalities that they can use to help alleviate symptoms, ice, heat, They can always use pain medications if that's appropriate per the physician. Activity modifications, different positions for sitting down, lying down. A lot of patients have trouble sleeping. They're in excruciating pain, which again gets into that vicious cycle of lacking sleep, stress, anxiety, which can flare them up as well. So a lot of it's educating them, knowing that some days/weeks are going to be better than others. They're already moving a little bit on their own, which they tend to do a little bit better over time. Again, time is the biggest thing. And then just showing them exercises to try to maintain what they currently have and try to help them improve their mobility over time as well as their strength. I see patients, again, 1 to 2 times a week for a few months. Eventually, patients become independent with everything that we've discussed as well as what I've shown them. So a lot of times patients end with PT, with home exercises that they end up doing over a long period of time. And we're not entirely sure if that is what is helping or if it's just the time aspect that their range of motion starts to improve. It's hard to tell. Life's not black or white. It's gray. So I like to believe that, a little bit of everything tends to be the best bang for your buck. So comprehensive rehab is the goal.
Thank you, Fareed and Dr. Weasel. I have a question from Charlie. Charlie shared his story. Charles, excuse me. Charles shared his story. Thank you, Charles. Great story. I think the question out of this is about acute shoulder pain. Can you talk about what are some causes for acute shoulder pain? So you might have pain in your shoulder for a short period of time that goes away. Is there anything potential? Is there anything else going on in your body, potentially your heart, that could cause acute shoulder pain, or could it be, I would think, injury related? Can you talk a little bit about, because it sounds like the rotator cuff, some of the other things that we talked about are longer term, you have pain for a longer period of time. What about acute pain? Can you talk about that, Dr. Weasel and Fareed?
Sure. So when you talk about acute shoulder pain, the first question is the pain actually coming from the shoulder? So you always have to first and foremost rule out is it a cardiac cause, as you sort of mentioned, because chest pain or cardiac pain can certainly present as chest pain, but it can present as jaw pain. It can present as pain going down the arm, as can some. Especially on the right side, some intra-abdominal causes of pain as well. The other sort of big area that will cause pain in the shoulder that's not coming from the shoulder is the neck. So if you have a pinched nerve in the neck, that can be, that can come on very suddenly and be quite acute pain, and that will cause pain up here and pain when you turn your head, but also pain that can radiate out to the shoulder, sometimes back of the shoulder, and then sometimes all the way down in the arm and cause numbness and tingling as well. So those are sort of 2 causes, I would say, or a couple causes of acute pain that are not specific to the shoulder. When we start moving towards the shoulder, they sort of fall into 2 categories. One is after trauma. So if there's been a significant trauma to the shoulder, you could have a shoulder dislocation or a shoulder fracture most of the time, or an acute tear of something like your rotator cuff. And then there are a few entities, one very, very common, some much less common, that can actually atraumatically cause really severe pain in the shoulder. The most common one of those that is very frequent is something called calcific tendonitis. And what happens there is you'll get I'm going to bring my model back up here. You'll get a deposit of some calcium sitting in the rotator cuff tendon itself. That actually most of the time doesn't cause a problem if it's just sitting there, and about 10% of people will have that with no problem. But if your body starts to reabsorb that calcium, it can cause severe pain because it causes an inflammatory response in that space up above the rotator cuff underneath the top of the shoulder blade. And that sort of characteristically will come on in 6 or 8 hours, and people will describe it as the worst pain they've ever had, end up going to the emergency room. The good news with that is when your body is absorbing it that quickly, most of the time it actually goes on and within a couple of days will go away completely. You just got to control your pain and the inflammation in the meantime. So I'm not sure if that's what he was sort of referring to, or if he was sort of referring to kind of recurrent sharp pains in the shoulder, and that's a little bit of a different issue.
Thank you. It sounded like it was a one-time kind of thing. So I think that you addressed that, but certainly if there were other questions, Charles, please let us know. Elizabeth, this question is for you. Did you have any sleeping challenges before you had your rotator cuff surgery, and how did you get around that? Were there ways that even before you had surgery and even after, and what you've been working with Fareed to get better sleep?
So I did have sleep challenges because when you move and you're asleep and you move, all of a sudden, if you move in a particular direction, then that causes pain in your shoulder. So I'm lucky. I tend to sleep on my back, which means that I'm just lay flat. But I also used to sleep I would sleep like this, and I couldn't do that anymore. And the first physical therapist that I saw said, whatever you do, sleep with your arms down. And that did help. So it wakes you up because you move without thinking in your sleep. And then after surgery, it was a long time before I could roll over onto my right side. I can do that now without any problems. So it's a matter of just finding a new way to sleep. It goes back to that education. I didn't really think about, why I was having the pain at first, and if I sleep like this, why that would cause even more pain to an already inflamed area. So it's a matter of just finding new ways to position your body, which can be hard because we tend to be creatures of habit.
Yeah, absolutely. Thank you. Fareed, any other tips that you give your patients as they are trying to acclimate after surgery?
Yeah, to piggyback on what Elizabeth said, I mean, the main thing is, and it's unfortunate, but it is honestly just the nature of what is going on, right? That is just part of the process. And, I try to work with patients in regards to, if there's a specific time and or place in which they feel it, maybe give them some modifications to improve their comfort. But in terms of eliminating the pain per se, that's kind of hard to do. It's just part of the rotator cuff surgery, as well as the body perceiving it as a threat, and the nervous system affecting everything. So main thing is just educating patients and trying to work with patients in trying to improve their comfort. Like Elizabeth said, the first physical therapist told her to bring the hand down, and for her, it worked best. So just trying to find different positions that are most comfortable. But again, I tell patients, look, it doesn't matter if it's the most comfortable position, eventually it will become uncomfortable. So main thing, just try to move around as best as they can. And to piggyback off of rotator cuff surgery, I know we didn't discuss too much about this, but after a rotator cuff repair, a patient is not in the sling forever. They are in the sling for about a month. If the patient, when they see Dr. Weasel, do have some range of motion limitations pretty significantly, then he'll send them over to me and do some passive range of motion one time a week or so to certain ranges of motion until they see them again. And then it's passive range of motion. So essentially what that means is you do not do this actively. That you definitely don't want to actively move the shoulder. Dr. Weasel will tell patients, it's okay to sit and type if you need to, especially nowadays with everyone working from home. That is fine, but definitely no overhead motions. So essentially not actively moving the shoulder. So I see patients and educate them on that, as well as show them some exercises, specifically with the pulleys. I find that being best for patients. They're able to relax, and then the other arm, the non-involved side, works to move the involved shoulder that they had surgery with. So that's 6 to 8 weeks. Every patient's a little different. Insurance benefits are a little different. So it could vary from 1 to 2 times a week, maybe every other week, depending on the independence of the patient. So that lasts 6 to 8 weeks, and then they'll see Dr. Weasel again, and hopefully be cleared for active range of motion and strengthening. So that's when the patient can officially move the shoulder above, shoulder height, and start doing the things that they were normally doing before. And then again, talked about before surgery, same idea. It's just about finding that right balance to where it's not too little or too much for the patient, minimizing the risk of re-injury and flare-ups and things like that, which is trial and error. So it's just working with the patient, trying to find the best amount of load for them. And then that could last anywhere from 3 to 6 months. But again, it varies between patient and patient.
I go back to the 2 words of patience and grace.
Yeah.
You have to have that long-term goal in mind, and you'll get there.
Yeah, and every day is not going to be the best day. Some days / weeks are going to be better than others. And so I spend a lot of my time reassuring patients that, hey, I understand you're not coming in as good as you were before, but it's like the stock market. It's not always green. There are some red days. So yeah, exactly. But it goes up, and you just hold on to everything that we've discussed, and there will be that light at the end of the tunnel. So.
Thank you for that. And Elizabeth, you're at the end of your journey. I know you're at the final stages of your process. Mm-hmm. So congratulations. I know, yes, very exciting time for you. Dr. Weasel, if a patient does not get to that point and say physical therapy takes longer or isn't successful and they don't have that clearing from you and that full range of motion, what are their next steps?
It depends a little bit on what the issue is, but rotator cuff surgery tends to work real well. We sort of talk about a 90 to 95% success rate in terms of getting people back pain-free to everything they want to do. Unfortunately, no surgery is 100% successful, and if you ever find a surgeon that tells you they never have any problems with their surgeries, you probably want to go look for a different one because they're lying to you. So it's the nature of surgery that it doesn't always go as we want. But most of the time, there are things we can do at that point to make it better. Sometimes patients just need a cortisone injection once they get 4 or 5 months out to kind of help calm things down and push them, control their pain a little bit better and push them in the right direction. Occasionally, patients will get very, very stiff after surgery. We know that the vast majority of the time that will come back. Sometimes, most people within a few months, but sometimes it'll take 6 or 9 months. Occasionally, we have to go back in and cut the scar tissue to get the shoulder moving again, and that tends to work quite well. And then there are some folks where the rotator cuff, despite everything we've done, doesn't heal. And that can be more of a difficult problem. Sometimes we're able to, depending on the condition of the tissue and the size of the tear, we can go back and repair it again. Sometimes we can talk about other options in terms of shoulder replacements at that point. But it does tend to be a good surgery, and what we'll say as Fareed and Elizabeth said, it is a little bit of a long course. I always tell people that the surgery itself takes about 45 minutes, so that's the easiest part, and everybody wants to know all about that. That's actually not the hard part. The hard part is the work that the patient puts in on their own, and then with the therapist over the next 4 to 6 months to really get them where they want to go.
Thank you so much. So Elizabeth, what is your message for our viewers who are suffering from shoulder pain and are considering a rotator cuff surgery?
It's interesting. Dr. Weasel just said that if you find a surgeon that says every surgery is successful, then go find somebody else because they're lying to you. I think first and foremost, you have to find a doctor that you trust. So it means becoming informed. It means doing your homework And if you have the opportunity of getting word of mouth, then do that. And if not, it's the reviews. I am grateful to my peers who have gone through similar surgeries and were able to tell me, this is the doctor I used, or this is the doctor I used, here's the experience I had. And so I think first and foremost, it's becoming informed and choosing the surgeon that's right for you. The second piece is in terms of my advice to folks who are experiencing pain and whether or not to go through surgery. I have a good friend of mine who just the other day fell and broke her wrist. And she experienced ageism for the first time, where the ER doctor said, well, they're not going to operate on your wrist because you're too old. And she said, what? And we discussed it. And she said, that's just baloney, because I want to play golf and I want to be able to hold my granddaughter. And I know this person and she will do the work that is necessary. So the other piece that I would ask folks to consider is it's not just a one-time deal where it's that 45 minutes under the knife with a surgeon. It's the believing in yourself. It's the becoming informed. It's building that alliance with your physical therapist. It's putting in the time that it takes to regain the strength and the range of motion, or almost range of motion, that you had, and working hard to do it. I'm a big believer in setting goals and accountability and following through. And so if you want the outcome, whatever that outcome may be, it's up to you to do that work. You can go and you can see the surgeon and you can have the surgery, and you can go and you can get the cortisone shots, and you can go and you can see the physical therapist. But bottom line, if you go to see the physical therapist once a week and don't do anything, then you have to ask yourself, was it worth it? So my advice is be informed, find someone you trust, actually two people you trust, because it's not just the surgeon, it's the physical therapist, and do your work.
Thank you so much, Elizabeth. That is a powerful message. And I just want to give you a kudos, because it sounds like you had a wonderful journey. And I'm really, proud to hear what you've gone through. And it's just a wonderful thing to share with our viewers. And to kind of echo on that, to close out our broadcast, one more kudos that we heard from our viewers. From Thomas, he says, greatest staff ever. And I'm sure, Elizabeth, you can agree with that, because I know you've worked very closely with Dr. Weasel and Fareed. And like you said, it's trust in not just the physician, but your team. So thank you for that, Thomas. Thank you, Elizabeth. Thank you, Dr. Weasel. Thank you, Fareed. That wraps up our broadcast. We will make sure to answer any additional questions that you had in the comments following our broadcast. And we invite you again to share this with your friends, encourage them to look into the services we have at MedStar Georgetown University Hospital. And if you are interested in scheduling an appointment, you can visit our website, which we'll put in the comments, or you can also call 202-444-5242. Thanks again very much. We'll see you next time.
Bye-bye. Thank you.
Thank you.